Hello everyone, and thank you for attending today's webinar. Before we begin, we want to cover a few housekeeping items. At the bottom of your audience console are multiple application widgets that you can use. You can expand each widget by clicking on the maximize icon on the top right of the widget or by simply dragging the bottom right corner of the widget panel. This webinar is being recorded, and the recording will be available one day after the webcast, both at the same audience link used for this webcast. If you have any questions for presenters during the webcast, you can click on the Q&A widget at the bottom and submit your questions. We will try to address as many questions as possible during this event. But if a fuller answer is required or will run out of time, your question will be answered later via email. We do capture all questions. If you have any technical difficulties, please click on the Help widget. It has a question mark icon and covers most common technical issues. You can also use the Q&A widget for technical issues. Now, I would like to pass it over to Susan Arday. Susan, you now have the floor.
Thank you very much, Derek. I really appreciate that. Good afternoon, everyone. Thank you, and I'd like to welcome everyone to today's webinar on electronic clinical quality measures. It's titled, and I will switch your slide here, Eligible Clinician eCQM Preventive Care and Screening Measures. This is the second in our eCQM series of webinars for eligible clinicians. As mentioned, my name is Susan Arday. I am the CMS Contracting Officer's representative for this particular action, and I am the core for the CMS contract tasked with maintaining the electronic clinical quality measures, or eCQMs, used in the CMS Merit-Based Incentive Payment System, abbreviated MIPS. I will be presenting today along with Katie Magulik and Gary Rezik from Quality Insights, and also Beth Bostrom and Jamie Lehner from PCPI. And today we'll present three measures. The first is Quality ID 317/CMS22, Preventive Care and Screening, Screening for High Blood Pressure and Follow-Up Documented. The second will be Quality ID 110/CMS147, Preventive Care and Screening, Influenza Immunization. And the third will be Quality ID 226/CMS138, Preventive Care and Screening, Tobacco Use, Screening, and Cessation Intervention. All three of these measures are in the top 10 reported eCQMs for MIPS. And as such, there's many questions that come in. So today our speakers will review the specifications and address the most common questions that are received. And as you'll see on this slide, at the end of today's session, you will, one, be familiar with the top reported preventive care and screening eCQMs. Two, you'll be better understand the most frequently asked questions and answers for each of these eCQMs and how to follow ongoing information about these measures. You'll also know how to go into JIRA through the ONC project tracking system to follow that information. Three, you'll also learn about changes to these eCQMs for 2019 MIPS reporting, including the new CQL updates. I would like to state that, I want to make note of this, that the staff and speakers have no financial arrangements or affiliations with corporate organizations that either provide educational grants to this program or that may be referenced in this activity. At this time, I will hand the presentation over to Katie Magulik and Gary Rezik from Quality Insights, who will discuss CMS 22, the Preventive Care and Screening Measure, Screening for High Blood Pressure and Follow-Up Documented. You have the floor, Katie.
Thanks, Susan. Again, my name is Katie Magulik, and I will first review the measure populations for CMS 22, Preventive Care and Screening, and then we'll discuss the most frequently asked questions that we receive from the community on this measure. Gary Rezik from Quality Insights will also provide us the changes for 2019 MIPS reporting for this measure to finish up the review, and then we'll field any questions at that time. So first, a review of the measure description. CMS 22 assesses the percentage of patients aged 18 years and older seen during the reporting period who are screened for high blood pressure, and a recommended follow-up plan is documented based on the current blood pressure reading as indicated. The denominator includes all patients aged 18 years and older at the beginning of the measurement period, with at least one eligible encounter during the measurement period. Denominator exclusions include any patient who has an active diagnosis of hypertension. The numerator includes patients who were screened for high blood pressure and have a recommended follow-up plan documented. As indicated, the blood pressure is prehypertensive or hypertensive. There are also two classifications of denominator exceptions for this measure. First, patient reasons, such as if a patient refuses to participate either in the blood pressure measurement or follow-up, or medical reasons, such as if the patient is in an emergent or urgent medical situation where time is of the essence and delayed treatment would jeopardize the patient's health status. This may include, but is not limited to, severely elevated blood pressure when immediate medical treatment is indicated. Our highest volume of questions were focused around denominator exception criteria. For a quick review, let's discuss the difference between measure exceptions and exclusions. Denominator exclusion criteria are evaluated before checking if a patient meets the numerator criteria. A patient who qualifies for the denominator exclusion would be removed from the denominator. And in this measure, again, a patient with an active diagnosis of hypertension would be a denominator exclusion. Denominator exception criteria are only evaluated if the patient does not meet the numerator criteria. Patients who do not meet numerator criteria and also meet denominator exception criteria, for example, a medical reason for not performing a screening, would be removed from the denominator. A way to think about exclusion versus exception logic is an order of operation. So when you go through the logic, you first review for measure inclusion in the initial population, then denominator exclusion, and so on. This is the order of how we evaluate these populations. So if a patient is excluded from the denominator, they will never get to the exception criteria. For denominator exception, a patient would only be removed from the denominator if the patient did not meet the numerator criteria. Otherwise, the patient is included. The measure logic cannot account for every reason of why or how a patient may fit into a measure. Denominator exceptions allow the provider more discretion to assess if a patient is appropriate for measure inclusion. An example of a patient that would qualify as a denominator exception would be a patient who receives a blood pressure screen during the eligible encounter. It is their first documented hypertensive reading, but they refuse follow-up. The patient did receive their screen, but is not receiving follow-up because they refused. Therefore, this patient would be removed from the denominator exception. Moving into our frequently asked questions. Our most frequently asked question requested clarification on what constitutes a denominator exception. The question we received: can the denominator exception criteria be documented outside an eligible encounter? And the answer is no. Any denominator exception criteria must be documented during the eligible encounter within the measurement period. So for example, a patient came in to see you last year and refused to have their blood pressure taken, and this was documented. When the patient returns the following year and happens to refuse again, this would need to be documented again to qualify as an exception. The denominator exception criteria must be documented each measurement period to meet measure intent. Next, we received questions regarding blood pressure screening timing. So the question was, Do we need verification that the blood pressure screening occurred during a qualifying encounter? The answer: the blood pressure screening must occur at the time of the qualifying encounter. The measure uses the most recent blood pressure reading from the last eligible encounter during the measurement period. For example, if a patient has 4 eligible encounters during the measurement period, and the blood pressure was taken at the first, second, and third encounters, but not the fourth, the measure would look at the third encounter. Again, the most recent eligible encounter with a blood pressure screening result is what is considered to meet measure intent. And our final most frequently asked question was regarding blood pressure follow-up timing. The question received: can the recommended follow-up for prehypertensive or hypertensive reading occur before the blood pressure screening encounter? The answer is no. The follow-up must begin concurrently with or start after the eligible blood pressure screening encounter. It cannot occur prior to the eligible encounter, and that follow-up must be ordered within 24 hours after the start of the encounter. As we discussed blood pressure reading follow-up in the previous slide, we'll go ahead and review the eligible follow-up interventions for this measure. A follow-up plan based on the current blood pressure reading must be documented to meet measure intent. Prehypertensive, first hypertensive, and second hypertensive readings require follow-up intervention orders within the specified time frames. Eligible follow-up intervention orders include any of the following: lifestyle recommendation, weight reduction recommendation, dietary recommendations, physical activity recommendations, moderation of alcohol consumption, and/or referral to an alternate provider. Prehypertensive readings require follow-up visits to be ordered within 1 year of the eligible encounter, while first hypertensive reading documentation requires a follow-up visit to be ordered within 4 weeks of the eligible encounter. Specifically, for a second hypertensive blood pressure reading, the follow-up must include one or more of the following as indicated: antihypertensive pharmacologic therapy, laboratory tests, or electrocardiogram. Next, Gary will go ahead and review the 2019 reporting changes with you.
Thanks, Katie. I'm going to talk a little bit about some of the coding and value set updates which impact CMS 22. So along with the conversion to CQL, measure specifications can now use what are called direct reference codes. And these are used in instances where a value set, only a single code, can be replaced with a direct reference to that single code instead of an OID, which identifies a value set. And for the 2019 reporting year, single code LOINC value sets have been transitioned to direct reference codes, with other coding terminologies being transitioned optionally. For CMS 22, the LOINC value sets that were used to define systolic and diastolic blood pressure have been transitioned to direct reference codes. And so to show you how this will appear in the new specifications, first I'll show you a snippet of the 2018 specs and how the blood pressure value sets appeared. In the data criteria section of the specs, you'll see the QDM data type along with the reference to the value set's name and the OID. Each of these value sets contained only one code. So it's in the 2019 specs, this is a bit of a subtle change here, but you no longer see an OID. You'll see the same QDM data types, and instead of a value set, you see the direct reference to the LOINC code. And there's the code description, the code terminology and version, which is in this case LOINC 2.63, and the code value. And the way this appears in the CQL logic, the data element is referred to by the code description as highlighted in this CQL definition, which is taken from the current measure specification. And other coding updates which have impacted this measure include the addition of 5 CPT codes in the denominator coding. And these codes allow for the inclusion of some nursing home and other assisted living encounters. And lastly, in the antihypertensive medication value set, several codes have been removed to reflect specific drug formulations which have been discontinued. Thanks.
Thank you, Katie and Gary. At this time, I would like to turn it over to Anita to see if there are questions that have come in through the chat.
Thank you, Susan. Yes, we have received several questions. Okay, so the first question that we have is, how would we show an exception?
Hi, this is Gary.
This is Susan Arday. Can the questioner clarify what they mean? How would they show an exception? Are they talking about in coding or in documentation?
It came from a practice. Charlotte Rogers from the Cardiac and Vascular Institute. So I would imagine, how are they submitting to show an exception?
And this is Gary. I'll try to answer that in maybe a bit of broad terms. And again, if the questioner wants to drill down, please follow up. But all of the exception criteria are defined in value sets. So those would need to be documented in the medical record as a reason why either the blood pressure wasn't taken or that the follow-up was not performed.
Thank you. The next question asks, when we are being audited to check this specific quality measure, can the auditor take any blood pressure measure reported during the reporting period, or do they have to take the last reported blood pressure?
And this is Gary again. Let me just speak to the measure specification and maybe not specifically to auditing, but the intent of the measure is to look at the most recent encounter where a blood pressure was taken in the measurement period.
Thanks, Gary. The next question says, so if a patient has 4 encounters and only 3 of the 4 yield a measurement, the patient would fail one of the 4 encounters?
No, that is incorrect. Again, we would only look at the most recent encounter where the blood pressure was taken. That is the index encounter, and that is where what the measure logic flows from. So you can have subsequent encounters where no blood pressure was taken. You could have previous encounters where the numerator criteria aren't met. As long as the most recent encounter with the blood pressure taken passes the numerator criteria, they would pass.
Thanks. The next question says, so if a provider stops taking blood pressure readings midway through the year, we just take that last blood pressure. Seems like that would encourage not taking blood pressures after you get one controlled reading.
So again, I can't speak to maybe some unintended consequences, but yes, the way the measure logic currently works is that we only look at the most recent one taken, and there can be subsequent encounters where blood pressure readings are not taken.
And the next question was is the blood pressure the most recent blood pressure or the blood pressure on the most recent encounter?
The most recent blood pressure during an eligible encounter that happens during the measurement period.
The next one is, could you please provide clarification on how a nurse visit encounter would qualify?
We may need to follow up on that. Again, if the encounter coding meets the denominator criteria, which again are defined in the value sets provided with the measure, it's an eligible encounter and would be counted, I think, regardless of who takes the blood pressure. Questions of sort of attribution and who that performance measure is assigned to are something I can't address at this time. But please follow up, and I'm sure we'll be talking later about how to submit follow-up questions that you may still have after the presentation.
Similar to that one, it was asking, can the follow-up be counted as a nurse visit? So it seems like they want to know if they come back for a nurse visit to have the blood pressure checked, can that count as follow-up?
Let me think about that. I don't, just with that information only, and again, I would encourage the person asking this question to maybe submit this with some more detail through JIRA. A follow-up at a later time with a nurse, I don't believe it is one of the codified, follow-up measures for this measure. You can have a referral to an alternate provider. There are certain requirements to address, to order a follow-up at the time the blood pressure is taken, but a nurse follow-up at a later date is not currently a valid intervention or follow-up plan for this measure.
Okay, the next one is, if hypertension is a visit diagnosis in an office or emergency department visit and is the only record of that diagnosis, should the patient still be in the denominator?
So I think that would depend how it's documented in the patient's record in the outpatient setting. If there is a record of that patient having a diagnosis of hypertension and it's documented in their record, that they would be excluded.
Great. So we are running tight on time. We promise all of these questions will get answered. We will get these out to you, and if there's still time at the end, we can come back. But right now, Susan, I need to turn it back to you for our next presenter.
Oh, thank you, Anita. Next, I'd like to introduce Beth Bostrom, and she's going to present CMS 147, Preventive Care and Screening, Influenza Immunization. So I'll click it forward here. Take it away, Beth.
Thanks, Susan. Hi, this is Beth Bostrom from the PCPI, and as Susan mentioned, today we'll be walking through the details and description for Quality ID 110, CMS 147, Preventive Care and Screening, Influenza Immunization. Similar to the last presentation, we'll also walk through some frequently asked questions for this measure, along with some changes and updates and value set changes for the measure. So as you can see on the screen, the measure description is the percentage of patients aged 6 months and older seen for a visit between October 1st and March 31st who received an influenza immunization or who reported previous receipt of an influenza immunization. The initial population is all patients aged 6 months and older seen for a visit during the measurement period. The denominator equals initial population and patients also seen for a visit between October 1st and March 31st. There are no denominator exclusions. For the numerator statement is patients who received an influenza immunization or who reported previous receipt of an influenza immunization. For the denominator exceptions, they are as follows. Documentation of medical reasons for not receiving the influenza immunization, such as a patient allergy or other medical reasons. Documentation of patient reasons for not receiving an influenza immunization, such as a patient declined or other patient reasons. And finally, a documentation of system reasons for not receiving the influenza immunization. such as the vaccine was not available or other system reasons. So moving into the frequently asked questions for this measure, the first that we'd like to start with is as follows. How many encounters are needed to meet the measure requirements? And the answer is you may only need one encounter to satisfy the initial population and denominator criteria. However, you could need two separate encounters depending upon the timing of those encounters. Now let's walk through a few scenarios to further demonstrate this point. So let's assume that 2018 is a measurement period. And as you can see on the screen, the initial population logic is that the birth date of the patient must be greater than or equal to 6 months at the start of the measurement period. And then there must also be the following list of encounters: the initial qualifying encounter during the measurement period, or hemodialysis during the measurement period, or peritoneal dialysis during the measurement period. So this means the encounter must take place between January 1st and December 31st, 2018. Now for the denominator, the requirements are as follows. It's the initial population as well as an encounter during the influenza season, or hemodialysis during the influenza season, or peritoneal dialysis during the influenza season. So that encounter must take place between October 1st, 2018 through March 31st, 2018. So again, moving forward with this scenario, continuing 2018 being our measurement period, let's take a look at scenario number 1. In this scenario, on January 5th, 2018, there's an office visit. Now this single visit meets both the initial population and the denominator criteria since it falls within the measurement period and the flu season. Moving forward to scenario 2, let's assume there was an office visit on October 2nd, 2018, and an office visit on June 1st, 2018. Now the first visit satisfies the denominator requirement as this falls within the flu season, but the patient isn't pulled into the initial population until June 1st because this satisfies the initial population requirement. Now for scenario 3, let's assume there's an office visit on June 1st, 2018, and an office visit on October 3rd, 2018. Although the patient has a visit that meets the initial population, there isn't a visit during the current flu season. So this situation may be counted towards the following reporting year. So this leads us into our next frequently asked question. What is the time frame in which the influenza immunization must be administered to meet the measure? And the answer is that the influenza immunization must be administered between August 1st through March 31st of the current flu season. For the purposes of this measure, the flu season begins on October 1st of the year prior to the measurement period and ends on March 31st during the measurement period. Now, the eCQM measurement period corresponds to a calendar year, which is January 1st through December 31st, as indicated in the measurement period field in the eMeasure header. For an eCQM, data is queried retrospectively, and the information is aggregated at the end of the measurement period, December 31st, in accordance with the program reporting guidelines. The measurement period serves as a timing anchor to query data for the specific flu season, including data from the previous year. In order to meet the measure, the influenza immunization must be administered between August 1st and March 31st of the current flu season. Within the measure specifications, the influenza season definition is defined as the start of the measurement period minus 90 days, and from the start of the measurement period plus 90 days. The minus 90 days accounts for October through December of the current flu season. The plus 90 days accounts for January through March of the current influenza season. The numerator of the measure may also be met if the influenza vaccination is administered between August 1st through December 31st of the current flu season. Within the specifications, the logic for this may be found in the numerator definition titled Influenza Season, including August and September of the prior year. This accounts for influenza vaccinations administered minus 153 days from the start of the measurement period to plus 90 days from the start of the measurement period, or from August through March of the current influenza season. Now, the eCQM only assesses the flu season that ends during the measurement period. This is noted within the measure's guidance field, but it is important to note that the guidance field is as follows. To enable reporting of this year's measure at the close of the reporting period, this measure will only assess the influenza season that ends in March of the reporting period. The subsequent influenza season, ending March of the following year, will be measured and reported in the following year. As an example, if the measurement period is January 1st through 2018 through March 31st, 2018, the influenza season included in the measure will be from August 1st, 2017 through March 31st, 2018. Moving forward to our next question, if a patient says they have already received a flu shot, how is this documented? So if a patient has already received a flu shot during the current influenza season, the patient will still meet the numerator using the quality data model data type, communication from patient to provider, and captured using the previous receipt of influenza vaccine value set. The previous receipt of influenza vaccine value set contains SNOMED CT concepts. Additionally, if the provider reporting on the measure is the one who administered the flu shot before the official start of the flu season on October 1st, that information may be pulled into the numerator to meet the measure as immunizations administered in August and September of the prior influenza season and will also qualify to meet the numerator. Another question that we often receive is, why are there two QDM data types to administer the influenza vaccine? Both procedure performed influenza vaccination and immunization administered influenza vaccine are included in the measure. And the answer is that the PCPI adheres to the terminology standards put forth in the CMS Measures Management System Blueprint and specified the measure using the immunization administered QDM data type and the influenza vaccine value set, which includes CVX codes. However, we've heard feedback from providers and implementers that CPT is commonly used to document the administration of a flu shot. So to allow for greater flexibility, we have included the procedure performed QDM data type and the influenza vaccination value set, which includes CPT codes. So finally, another question that we received is if the measurement period is 2018 and a patient has an allergy to eggs that starts on July 1st, 2018 and ends on February 1st, 2019, does this qualify as a valid exception? And the answer is that this patient does not qualify for a valid exception. So in order for a patient to qualify as an exception, their allergy must be active for the entire current flu season. The allergy noted in the question starts on July 1st, 2018 and ends on February 1st, 2019. This is after the end of the flu season, which is October 1st, 2017 through March 31st, 2018, being reported on for the 2018 measurement period. Because of this, the allergy would not be an applicable exception for that reporting year. This is reflected within the specifications and the diagnosis of allergy to egg definition. The allergy diagnosis must overlap after the influenza season, meaning any allergy that ends before the flu season ends would not qualify as a valid exception. So lastly, I'd like to walk you through some coding updates for 2019. Below are a couple of value sets that we updated as a part of annual maintenance, including our patient reason value set. We also updated the influenza vaccine value set based on updates as a part of just annual maintenance. We also updated the influenza vaccination value set as a part of annual maintenance. So moving along, as a part of the annual update process, the face-to-face interaction value set which is stewarded by NCQA, was removed from the program. So because of this, extensional value sets for encounters to replace the face-to-face interaction value set were created. They are as follows. We removed face-to-face interaction, and then we added the following value sets: care services in a long-term residential facility. We also added a home health care services extensional SNOMED CT value set, a nursing facility visit SNOMED CT value set, an office visit SNOMED CT value set, and an outpatient consultation SNOMED CT value set. And as I mentioned, because face-to-face interaction value set was removed from the program, to account for the codes in the value set, PCPI kept the encounter influenza grouping value set and added the following extensional value sets as displayed on the screen to account for the encounters which would meet the measures.
Thank you, Beth. At this time, I'd like to turn it over to Anita to see if there are any questions that have come in through the chat.
Once again, a lot of interest in this measure. So the first question is, do you get dinged if the patient refuses this vaccine?
So the way that we would account for a patient refusing a vaccine, this would be accounted for in an exception, which is, I will go back to slide 22 for the measure description. The documentation of patient reason. So this would be accounted for with the patient reason value set and documenting a valid exception if a patient does decline.
Thank you. The next question is, if a provider does not immunize, is the shot record the best way to satisfy this measure?
So in order to, and maybe we could follow up offline about this if it is a little bit more detailed question, but within the measure specifications, a patient could report previous receipt if they already had an influenza immunization administered within the influenza season. Otherwise, ideally, that provider would administer the influenza immunization during that visit. But if the provider would never immunize, then this isn't a measure that would be appropriate for them to report on.
Thank you. The next question is, are we expected to be giving influenza vaccines for emergency department visits? And I'm not sure if you showed the CPT codes or not there, whether the CPT codes include emergency department.
So to the best, let me go to that slide. But I don't believe we include emergency department visits. That should not qualify as an encounter that would meet this measure. So no, that would not. Emergency department visits in this measure.
Okay, thank you. Has any thought been given to changing the October 1st date since the recommendation to start getting the vaccine has changed to August and September?
That's a good question. As a part of our annual maintenance process, we convene a technical expert panel who reviews the updated guidance and recommendations. I will say that although within the specifications, the influenza season is October through March, you do still meet the measure, and that is accounted for. August through September of the influenza season are accounted for and would meet the numerator for this measure.
Great. The next one, is there an interpreter to easily convert CQL to SQL? Otherwise, everyone will need to rewrite all this logic to run in a database and variance will ensue.
That is a good question that I may have to circle back with CMS on. Susan, I'm not sure if you have any other thoughts on that.
Thanks, Beth. I was just thinking about the same thing. CQL to SQL. top of my head, I am not aware of any. I don't believe our Bonnie tool does that, or the Bonnie tool that we use through ONC. That's a great question, though. A good place to send that in so we can make sure we answer your question fully and appropriately is if the questioner would send that into qpp@cms.hhs.gov.
And then the next, can you satisfy? And again, we will be taking all of these questions, going through them one by one to make sure that they get answered and consulting with CMS as needed. So the next question is, can you satisfy both denominator and numerator during a single visit?
Yeah, that's a great question. I'll actually go back to one of my first frequently asked questions. So I'm going to go to slide 25. And as we mentioned, or actually I'll go to slide 24. So you could meet both the initial population and denominator. It all just depends on the timing of the visit. So if the timing of the encounter, like we mentioned, actually I'll go forward one slide. In the first scenario, if 2018 was your measurement period, and say you had an office visit on January 5th, it meets the initial population and the denominator since it's within the measurement period and within the current flu season. So it all depends on the timing of the visit, but in some instances, the initial population and denominator could be satisfied by one visit.
Okay. What is meant by the denominator exception requirement stating, for example, patient has allergy to eggs whose prevalence must start after influenza season? What does this mean?
I think they are referring to the specifications themselves. Would you mind repeating that one more time, Anita? I just pulled up the specification documentation.
Sure. What is meant by the denominator exception requirement stating patient has allergy to eggs whose prevalence must start after influenza season? What does this mean?
So that all refers to the timing of the diagnosis of allergy to eggs. So within the specifications themselves, the diagnosis of allergy to egg must overlap after, but it wouldn't start after. It overlaps after. So it must be active through the end of the influenza season. I'm not sure if that helps clarify things a bit. Otherwise, I'd be happy to follow up after.
And once again, we need to get on to our final presentation, so I'm going to turn it back over to Susan, but I just want to emphasize we will get all of your questions answered.
Thank you, Anita. I'm going to advance this forward now very quickly, so bear with me, folks. I'm moving it forward to slide 47 here. Nope. 34, I'm sorry. And we will next hear from Jamie Lehner of PCPI, and she's going to go over Quality ID 226, otherwise known as CMS 138, Preventive Care and Screening, Tobacco Use, Screening, and Cessation Intervention. Jamie, you have the floor.
Thank you, Susan. This is a very, I think, commonly known measure, and so we are going to go through several questions that we have gotten frequently, especially with respect to the change from a single reporting rate to multiple. So hopefully, if you have any questions, we will get through those in these next slides. As a high level, just to review the measure description for CMS 138 Quality ID 226, it is the percentage of patients aged 18 years and older who were screened for tobacco use one or more times within 24 months and who received tobacco cessation intervention if identified as a tobacco user. We do have 3 different reporting rates or population criteria. The first is the percentage of patients aged 18 years or older who were screened for tobacco use one or more times within 24 months. The second is patients aged 18 years and older who were screened for tobacco use and identified as a tobacco user who received tobacco cessation intervention. And the third is essentially a combination of those clinical actions where we look for those patients 18 and older screened for tobacco use one or more times, and who received tobacco cessation intervention if identified as a tobacco user. So we're going to take these next few slides to sort of go through the individual populations at a closer look. Population 1, for the initial population and denominator, we are looking for all patients aged 18 years and older seen for at least 2 visits or at least 1 preventive visit during the measurement period. There are 2 different buckets of types of encounters that you can have in order to satisfy this particular requirement. So paying attention to the measure specifications is important to know which types of encounters fall into the count greater than or equal to 1 or count greater than or equal to 2 requirement. The numerator for population 1 is patients who are screened for tobacco use at least once within 24 months. That includes both the measurement period and the year prior to the measurement period. Finally, this population has a denominator exception for documentation of medical reason for not screening for tobacco use, and we include limited life expectancy diagnosis or other medical reasons to satisfy that valid exception. Population 2, we see some things that are similar, but what is important to note is that we actually have a smaller denominator for this population, where we're looking for all patients aged 18 years and older seen for at least 2 visits or at least 1 preventive visit during the measurement period. We further constrain that denominator to patients who were screened for tobacco use and identified as a tobacco user. This is actually taking a subset of those patients who met the numerator of population 1 and pulling that into the denominator for population 2, which is how we further narrow that down. The numerator for population 2 is patients who received tobacco cessation intervention. Again, we do have a valid denominator exception, a documented medical reason for not providing tobacco cessation intervention, and this does include, again, that limited life expectancy or another medical reason. Finally, in population 3, we get back to the initial, or the same initial population and denominator as population 1, all patients aged 18 years and older seen for at least 2 visits or at least 1 preventive visit during the measurement period. And our numerator looks at both of the clinical actions. So we determine if a patient was screened for tobacco use at least once within 24 months and who received tobacco cessation intervention if identified as a tobacco user. The denominator exceptions combine those from populations 1 and 2. So it is a documentation of medical reason for not screening for tobacco use or a documentation of a medical reason for not providing tobacco cessation intervention if that patient was identified as a user. So one of the most frequently asked questions is, why was this measure split into 3 populations? It seems very cumbersome and very challenging to understand that, but the reason why was because in order to see where improvement was needed or where a gap in care existed, the measure was split into these different populations based on the screening and the cessation intervention components. Prior to that, when you looked at the performance score for a measure, for this measure, you couldn't necessarily see whether the provider was not performing the screening clinical action, or if that provider was screening, maybe okay, but if they weren't providing all the cessation interventions that should be provided to those patients who were tobacco users. So beginning in last year's implementation period, 2018, we can utilize the 3rd rate, which effectively translates the measure into the way that it has previously been included in the program, to compare performance scores across program years. So you can sort of see a clinician is able to determine whether or not they've changed drastically in the overall rate, but again, looking more importantly at those various clinical actions independently to determine where the gap in care has been. Another question is, what is the difference between the populations, and can we just add the scores of populations 1 and 2 in order to get the performance score for population 3? The answer is no, we can't add those populations 1 and 2 together in order to get the score for the 3rd, because population 2's denominator, as I mentioned before, is actually a subset of the denominator used in populations 1 and 3. So here we're going to take a little bit of a closer look with an example. Assuming that the performance period is 2018, we are going to assume that the sample size for this, or the reported size for this patient population is 100. So in population 1, looking at the far left, we are finding that we are looking for patients 18 years and older with one preventive visit, and we have 100 patients meeting that criterion. The numerator for this population assesses whether or not the patients were screened for tobacco use, and we see that we have 80 patients who've met that. There are 10 patients who meet the medical reason for not screening, and so when we go to the bottom, we look at the performance score where we have 80 as the numerator divided by 100, which is the initial population or denominator, minus the valid exceptions of 10. So we have 80 over 90, which equals 88.9%. Using very similar numbers and carrying this over to population 2, we again find that 100 patients to start with in the initial population, but recalling that that denominator for population 2 is only a subset. So of those 80 patients who were screened for tobacco use, 50 of them were identified as tobacco users. It's that 50 number that's going to be used as the base denominator or eligible population for population 2. The numerator looks to see if those users had received tobacco cessation intervention, and we have 20 meeting that criteria. Again, we find that we have 10 patients with a medical reason for not providing cessation intervention. And so our performance score is 20 divided by 50 minus 10, so 20 over 40 is 50%. Now you can see if we were going to add these two together, it would equate to something far above 100%, so we know that we can't do that. But taking a look at population 3 on the far right, we again find the 100 patients meeting the age and the encounter criteria. Patients screened for tobacco use who are identified as non-users is 30. Patients screened for tobacco use identified as a user is 50. And so that is where that combines to create our 80 that we use in population 1, you might recall, for the numerator. The tobacco users who received cessation intervention is at 20. And combining those two valid medical exceptions, we have 20 patients who are going to be removed from that eligible population. So below we have our performance score of 30 plus 20, so that's the non-users plus the users who received tobacco cessation intervention, divided by our initial population 100 minus the denominator exceptions of 20. So we have 50 over 80, and we have 62.5%. Another common question that we receive with this measure is, do I need to screen my patient at every visit in order to meet the measure? No, you do not have to screen that patient at every single visit. The measure requires that patients have an encounter during the measurement period to satisfy one of the initial population or denominator requirements, and that can be either the 1 or 2 type of encounter buckets. However, the screening must happen at least once within a 24-month period. So this can be during the measurement period or the year prior. The numerator of the measure looks at the most recent screening during that time frame. So if the patient was screened multiple times, the measure is only going to look at the last one or the one that's closest to the end of the measurement period. Continuing for a little bit more of an example here, let's assume again that the measurement period is 2018. So in terms of looking for that 24-month period, we're looking at 2018 and 2017 for the clinical actions. In this patient example, we have 4 different visits or 4 different screenings. And so assuming that patient meets the initial population, age, and encounter criteria, we can see that the patient was screened on March 1st of 2017, and they were identified as a tobacco non-user. However, later in the year, December 20th, the patient was screened again and identified as a tobacco user. They also received tobacco cessation intervention on December 20th, 2017. However, during the measurement period, they were screened again on May 1st and identified as a tobacco non-user. But right before the end of the year, on December 2nd, the patient was again screened and identified as a tobacco user. However, it's important to note that there was no tobacco cessation given and no valid medical reason documented. If we're to take a look at whether or not this patient with these specific pieces meets or fails a measure or the population, we take a look at population 1 in which they pass. So the patient was screened for tobacco use at least once within the 24-month period. Moving on to population 2, we will actually report this measure for this patient because at the most recent tobacco screening, they were identified as a tobacco user. So we're going to satisfy that denominator criteria. However, they did not receive the cessation intervention, and they also did not have a valid denominator exception. And so this patient would fail population 2. Moving into population 3, we again know that we have the initial population criteria met. But moving into the numerator, although this patient met the screening component, they did not satisfy the cessation intervention component. And so therefore, this patient would fail in population 3. Finally, for our frequently asked questions, which population is being used for reporting purposes? According to CMS's QPP documentation for 2018, it is the second population's performance score that is being used. However, we do recommend reviewing QPP documentation each implementation year in order to make sure that you are getting the most up-to-date information and implementation for this particular measure. The last piece, just following up with what Gary and Beth have presented for the other 2 measures, are some coding changes for 2019 implementation. As mentioned before, the face-to-face interaction value set for the encounters was removed, and those individual SNOMED extensionals have been added to the home health care services and office visit value sets for this measure. Finally, our value set for limited life expectancy did have 1 new SNOMED code added, and that was based on some external requests that came through and requesting that we consider adding this particular concept. And it was determined that it met the intent of the value set, and so we've included it for this current year's implementation. That concludes the frequently asked questions and significant changes to coding for 2019. So I'll turn things back over to Susan.
Thank you. Do we have any questions at this time? I'd like to quickly turn it over to Anita.
We have several questions, but we are very limited on time, Susan. The first question was asking, isn't this measure topped out?
I can take that. This is Susan Arday. No, not according to our most recent benchmarks. You may be thinking, when you're thinking that this measure's topped out, what the rate would look like for population 3, and typically that could be topped out. But we benchmark off of population 2, and clearly in our most recent and historic analyses that we're not topped out on that, on any of eCQM or CQM or any other registry type specification for this measure.
Okay, and I think we only have time for one more. With the recent boom of patients converting to vaping, will these measures pertain to them? Specifically, if they achieve cessation through conversion, via conversion to vaping, will that count?
This is a great question, and actually the measure provides guidance surrounding this. Because there's not a lot of evidence to support electronic nicotine devices as either tobacco use or as a method for ceasing tobacco use and sort of, again, converting off of that, it has not been included, these ends have not been included in the measure specifications. We continue to look at more recent guidance and publications available in order to see if there is, we can sway things one way or another or put these into one of those appropriate buckets. But because nothing really finite exists, we have not done that. Again, there is guidance within CMS 138, the eCQM. I believe that there is also some guidance within the claims registry and web interface specifications.
Thank you. At this time, Susan, I'm going to turn it back to you to close it out.
Great. Thanks, Anita. I'd like to thank everyone for joining us today. The slide deck and all of the Q&As from today's webinar will be made available and accessible through the Electronic Clinical Quality Improvement Resource Center. The Resource Center contains information on the preventive care and screening measures as well as the measure specifications for 2019 reporting. Additional questions or issues may be submitted to the eCQM issue tracker in JIRA or in the ONC project tracking system. Next slide here shows you, I won't go through it in detail because we're running out of time, but to submit a question through JIRA and the ONC project tracking system, please follow the instructions outlined on this slide to create an account if you don't already have one, and then follow it up with an issue ticket. And finally, I'd like to again thank you all and thank everyone that was presented today. The next eCQM webinar, which will focus on diabetes measurement, will be held on January 30th, 2019, from noon to 1 p.m. Eastern Time. Registration has been distributed and is also available on the eCQI Resource Center. Thank you for attending today, and goodbye.